Next, we'll see about the last chapter in this immunity, which is transplant and graft pathology. So, we'll see about the various terminologies used here first. So, what is an autograft? Auto means self, right? So, a graft is taken from the same person and placed somewhere else, like a skin graft or a hair transplant, we do know. So, these are all examples of the autograft. Allograft is between the same species. So, one human to another human. So, we donate kidneys, right? So, that kind of a thing is called as the allograft. Isograft is between identical twins. So, identical twins, between them, they are doing transplant. It is the best transplant basically. So, that is isograft. Then comes xenograft. So, xenograft is between different species, like human to pig. So, we use pig heart valves usually. So, that is an example of the xenograft. So, now we move on to the various graft reactions. So, there are two types of reactions. One is the transplant rejection, another one is the graft versus host disease. So, transplant rejection is the one in which the host is going to act against the graft. Suppose there is a graft implanted into a person. So, the host is going to attack the graft and the graft will be rejected. So, the graft failure is going to be caused. So, host attacking the graft is called as the transplant rejection, while the reverse of it, that is, the transplanted graft is going to attack the host tissue. Okay, so that scenario is the one which we are going to call as the GVHD. Okay, so first we'll see about the transplant rejection. So, transplant rejection can be because of two pathways, a direct pathway and an indirect pathway. Direct pathway is the one in which the donor APC, that is the graft which contains the donor antigen presenting cells. So, the donor cells, the antigen presenting cells itself will take up the graft cell, antigens and present it to the host T cells. Okay, so when this happens, the T cells will get activated into either a CD4 T cell or a CD8 T cell. When CD4 T cells are being activated, obviously it is going to produce various interleukins, various cytokines, and that will recruit the inflammatory cells, which will in turn cause the destruction of the graft. Then cytotoxic CD T cells can also be formed, and these cytotoxic T cells will directly act against the graft and cause the graft failure. Okay, that is direct pathway. In indirect pathway, what happens is here the host APCs. Okay, so the recipient's antigen presenting cells itself will go and take up the graft antigens and present it to the host T cells itself. So again, this host T cells will again form the CD4 and CD8 T cells and cause rejection of the graft. Okay, direct is when the donor APC is causing the problem, while indirect pathway is when the host APC itself will take up the antigen of the graft. So, let's see about the types of the transplant rejection. We have hyperacute rejection, acute rejection, and chronic rejection. So, hyperacute rejection is the immediate reaction which happens within 48 hours. So, within 48 hours of transplantation of the graft, there is going to be graft rejection. So, it is a type 2 hypersensitivity reaction. Okay, because there is going to be preformed or antibodies formed. So, how do these preformed antibodies are present? Only when there is something preformed, it is going to have an immediate reaction. Okay, so preformed antibodies are usually formed when there was an exposure of the donor's antigens to the recipient. Suppose the donor had already given some blood transfusion or during pregnancy, suppose the mother is giving a transplant to her kid. So, in that case, during pregnancy, there might have been preformed antibody formation, or there is a previous transplant history itself from the same person. So, in that case, preformed antibodies must have already formed. So, they are ready to attack already. So, once immediately when you are putting the graft inside the body of the recipient, this antibody, preformed antibodies will immediately go and attach to the endothelial antigens present in the graft. Okay, so graft will again contain the vessels. So against the vessels present in the graft, this antibodies will go and attack them and cause complement activation. So usual type 2 hypersensitivity reaction is going to take place, and here it is going to result in the formation of thrombus, fibrinoid necrosis along with the inflammation. So all of this is going to be seen in hyperacute rejection. And this endothelial cells which are being attacked, they are going to when this blood vessels are not going to be proper, it is going to cause the hypoxia of the graft, resulting in the graft failure. So the graft will immediately, within 48 hours, the graft will undergo cyanosis and mottled. Okay, so suppose this bigger graft has been placed, it will immediately become very small and it will become cyanosed. Okay, that is hyperacute graft rejection. It can happen on table also. As soon as you place the graft, immediately before they close the surgery itself, the graft can be rejected. That kind of hyperacute rejection can be seen. Okay, so this was because of preformed antibodies, which was an example of type 2 hypersensitivity. Let's move on to acute rejection. So acute rejection can either be of two types, a cellular rejection or a humoral rejection. Okay, so this is the most common type of graft rejection, and here it takes days to weeks. Okay, and here it is both type 2 and type 4 hypersensitivity reaction. Okay, so type 2 because it is a acute humoral rejection, antibodies are going to play again here, so antibodies will come under type 2. And cellular rejection, it is going to be type 4, right? Cell mediated hypersensitivity. Okay, both type 2 and type 4 hypersensitivity is going to be seen in acute and chronic rejection as well. So why is it not type 3, you might ask? Here because the antibodies are going to be acting against the fixed antigen on the graft. Okay, so in the graft the antigen is fixed, so that is a fixed tissue against which the antibodies are going to come and attack. So it is a type 2 hypersensitivity. In acute cellular rejection, if you see, it is going to be basically because of the direct pathway. So direct pathway, I already told, it is going to be donor's APC, which is again which is taking up the graft antigen to the host T cells. So that will result in the acute cellular rejection. So there after that, the host T cells will get activated into CD4 and CD8. CD4 cells forming interleukins and cytokines, recruiting the inflammatory cells causing the death, and CD8 cells which are directly cytotoxic to the graft. So that much we are already seen, right? So that is the basis for acute cellular rejection. Under acute humoral rejection, if you see, here again the antibodies which are going to be formed is going to take some time to form. Okay, so they are going to be newly synthesized against this graft. So these antibodies will again come and attack the vessels present in the graft, and that will activate the complement pathway, resulting in the endothelial injury, inflammation, and that will cause the graft failure here. And classically, if you see, this classical complement pathway is being activated here, and this complement is going to go and deposit on the vessels. Okay, exactly what C4D deposits are going to be seen in a subendothelial location of the grafts. Okay, so this is very important MCQ. In acute humoral rejection, you are going to see C4D deposits on the subendothelial location of the graft. And this is actually called as the marker of acute humoral rejection. Okay, marker of acute humoral rejection will be C4D. Then chronic rejection. So in chronic rejection, it is going to take months to years. So it's going to take a lot of time. And here it is going to be because of, again, type 2 and type 4 hypersensitivity. This again is going to be classified into cellular rejection and humoral rejection. So humoral rejection is going to be part of the type 2 hypersensitivity. Cellular rejection is going to be the type 4 hypersensitivity. Here in the cellular rejection, here actually it is the indirect pathway. So indirect pathway, what will happen? The host APC will have to go and take up the donor's antigen, and then it will present it to the host T cells. So it is going to take some time. So this is the indirect pathway which is involved in the chronic rejection. So again, when this host T cells are activated, same story is going to happen. CD4 cells will be activated, then CD8 T cells can be activated. Also, what happens is when these T cells are activated, they are going to secrete some cytokines which are responsible for causing fibrosis. Okay, so anything related to chronicity, I already mentioned, there will be fibrosis. So here the vascular smooth muscles and the fibroblastic proliferation, so neointimal proliferation or fibrointimal proliferation will take place in the graft, resulting in the interstitial chronic inflammation. Along with that, you are going to see arterial sclerosis. So sclerosis of the vessels is going to happen, and if it is a kidney, you are going to see tubular atrophy as well. So all of these features are classical of a chronic cellular rejection. Okay, Indirect pathway is activated, resulting in fibrosis. So usually we call it as IFTA. Okay, IFTA stands for interstitial fibrosis. TA stands for tubular atrophy. Along with that, you get to see arteriolar sclerosis. Okay. Humoral rejection, again here you are going to form on the antibodies. Antibodies are going to act against the graft and cause the graft rejection. Okay, this much is for transplant rejection. So how do you prevent this transplant rejection? So you have to do a HLA matching prior, so that only compatible grafts are going to be placed in the recipient. So usually we are going to match 5 different HLA genes, which are HLA A, B, DRB1 and DQ as well. Okay, so HLA A, B, C, HLA DRB1 and HLA DQ, all of this is going to be matched for. So in each of this is going to have 2 alleles. So basically 10 alleles is there, but usually we take 8 alleles for matching. Okay, so DRB1 is going to be the most important one. In adults, we are going to use only 6 out of this 8 alleles. Okay, so even if 6 matching is there, we can proceed with the transplant. And most important of this will be the HLA DRB1. Okay, for kids you will have to take the cord blood, and here you can use 6 alleles. So out of the 6 alleles, you will have to at least have 4 alleles for matching. Okay, and here the 4 alleles will be usually HLA DRB1 more than B more than A. Okay, so in this order you will have to match it. Only in identical twins you'll have a 6 to 6 matching will be possible. So in child, even if 4 out of the 6 alleles is matching, you can proceed, and in adults it should be at least 6 out of the alleles is positive, then you can proceed. So other than this HLA matching, you will also have to immunosuppress the individual who is receiving the graft. So immunosuppression can be done with the help of drugs like steroids, then IV immunoglobulins, then immunosuppressive drugs like mycophenolate mofetil, tacrolimus. All of this will lead to the immunosuppression of the individual, after which you can proceed with the graft. So now we have done with the first type of graft reaction, which is transplant rejection. Next we'll see about graft versus host disease, which was basically the graft which is attacking the host tissue, that is the recipient tissue. So graft is in this case, the graft will be actually having the immunocompetent cells, and the host, the recipient, will be actually immunosuppressed. In this case, the immunocompetent cells present in the graft is going to attack the immunosuppressed host. Okay, usually it happens post hematopoietic stem cell transplant. So after blood transplantation, bone marrow transplantation, you are going to have this GVHD. So we have 2 types of GVHD, acute and chronic. So initially it was classified based on the number of days. So if the features of acute GVHD happens within 100 days, then they called it as acute GVHD, and more than 100 days it was termed as chronic GVHD. But now that has been considered obsolete. It is based on the manifestations of the GVHD. It is classified into acute and chronic. So let's see about the various manifestations. So acute usually happens within days to weeks only. And here it is going to involve the skin, liver and intestine. So in the skin, they are going to have a maculopapular rash. So a rash will be present. In liver, they are going to present with jaundice. And in intestine, they are going to present with bloody diarrhea. So these are the features of acute GVHD. While in chronic GVHD, it is going to be of insidious onset. And here again, skin, liver and GIT is going to be affected. But in skin, it is any chronic, I've already mentioned, there is going to be fibrosis, right? So fibrosis kind of manifestation you have to think about. So in the skin, the dermis is going to be completely fibrosed. So when this is fibrosed, the dermal appendages will be destroyed. In liver, it is going to cause a cholestatic kind of picture. So cholestasis will be present. And in GIT, you can have multiple strictures, especially in the esophagus and intestine. Okay. So when esophagus is undergoing stricture, the patient will feel dysphagia. They will not be able to swallow properly. Okay. So based on these manifestations, they classify it into acute GVHD and chronic GVHD. So, in the most common cancer which we see in a patient who has undergone transplantation would be actually a skin cancer. Okay, skin cancer more than non-Hodgkin's lymphoma, and skin also it is squamous cell carcinoma, which is you'll not expect it, right? So, squamous cell carcinoma is the most common cancer in a patient who has undergone transplantation.